Hi, my name is Brian Hefflinger, and if you're watching this video, you more than likely just saw me recently in the office regarding your neck or lower back. I know office visits are short, and I know a lot of your questions go unanswered because of the limited amount of time that we have. So I created this video as a quick reference for you to look at when needed. I'm going to try to go over what your films may have looked like in the office. I also want to describe your surgery in detail for you. We'll go over all the risk and benefits of the surgery. I'll try to include treatment options other than surgery. And then if you do end up having surgery, I will include all your post-operative care, including questions that maybe you didn't have time in the office to ask. Again, I want this to be a somewhat recreation of your visit that you had with me in the office. And I want it to be a quick reference guide so you can look back on this video and review things that maybe we covered too quickly or did not have a chance to cover during our office visit. Part of your visit in the office, actually a big part of it, is going over your films. And when you were in the office, we went over your MRI or whatever study you had that day. I reviewed it with you. I know it's hard to remember because we could do over it fairly quickly, so I thought I'd take this opportunity to show you a film that may be representative of what your film may have looked like in the office. So I'd like to show you an MRI that may be representative of your MRI that we reviewed in the office. Just to refresh you on how to look at an MRI, this is a side view of the MRI. This is the tailbone down here. This is your fifth, fourth, third, second, and first bone in your lower back. In between the bones are the dark spaces here, which are the disc. And then the spinal canal is right here. The white stuff is spinal fluid in the spinal canal, and the gray stripes that you see are the nerves that go through the spinal canal. This is the outside of your back, and this would be the front of the abdomen. So again, we're looking in from the side, and the first thing that you see is you can see the spinal canal gets pinched off right here. So you can see there's lots of white above and lots of white below, which is the spinal fluid. But in the area where there is the spinal stenosis, you can see that the nerves get pinched off. So this is a good example of severe spinal stenosis or severe narrowing of the spinal canal between the fourth and fifth bone. Now, some people have multiple levels, and you may have had more than one level on your MRI in the office, but this is a good example of what the spinal stenosis looks like on an MRI. I also want to show you another way to look at this that we may have looked at in the office. This is a picture looking from a top-down view. So this is the front of your abdomen out here, this is the outside of your back, and we're looking straight down the center of your spinal canal. That's how big you want your spinal canal to look. The white stuff is the spinal fluid, the little dots are the nerves, but that's how big you want your spinal canal to look. So that's a normal looking level. If we come down here, that's a fairly normal looking level. As we come down to the area of narrowing, you can see now you don't see any white in here. So the spinal canal is severely narrowed, and all the nerves are being pinched off, just like the waist of an hourglass. The waist of an hourglass gets very narrowed. That's what's happening to the spine here, and that's how the nerves get pinched. So when I do surgery, I actually take bone off the back of the spine to open up the spinal canal back to normal size, and by doing that, that will unpinch the nerves, which helps relieve your symptoms. To look at things a little bit differently, instead of looking at x-rays and an MRI, let me show you a model of the spine. So this is a model of the lower lumbar spine. And the way you look at it, these bumps or protrusions that you see here, these are called spinous processes. So when you push on your back in the center and feel the bumps in your back, that's what you're feeling, the spinous processes. Attached to the spinous process is the lamina bone. So when you hear of people having a laminectomy, this bone here attached to the spinous process is being taken. And then out to the side here and here is the joints of the spine. So for instance, if you were to have a simple laminectomy done to unpinch the nerve, say for a herniated disc, what I would do is I would take a portion of the lamina. So I would do a partial laminectomy to open up the space for the nerve. That would help to unpinch the nerve, as well as to give me access to where the nerve is. And then what I would do is gently move the nerve over a little bit and underneath there would be the disc, and I would trim the disc off to further unpinch the nerve. So that would be called a partial laminectomy on one side. For those of you who may have spinal stenosis, which is narrowing of the spinal canal, what I would do is take bone off the side of the spine on both sides. And in many patients, I will take the spinous process along with the attached lamina off completely, and that would open up your spinal canal completely to treat the narrowing of the spinal canal. If you're having surgery on the back of your neck, it would be the same identical procedure. I would take bone off the back of your spine on one side or both sides, depending on if I'm going to unpinch a nerve or if I'm going to unpinch the spinal cord. But that's the basics of what surgery from the back side of your spine would entail, and that's the anatomy, including the lamina, what a laminectomy means. Laminectomy means to remove the bone off the back of the spine to unpinch a nerve, the spinal sac, or to unpinch the spinal cord.
Hi, my name is Crystal and I'm a physician assistant who works with Dr. Hefflinger. Oftentimes you'll see a physician assistant at some point during your surgical care. I see you in the hospital on your first day after surgery. 90% of our patients will go home on the first day after surgery, so it's during that morning that we go through a lot of important instructions as far as wound care, activity restrictions and limitations after surgery, as well as follow-up. So we'll review those today together so you have a reference for you when you go home in case you miss any of those instructions. First, we'll talk about wound care. You'll either have dissolvable stitches under the skin, which do not need to be taken out, or you'll have skin staples closing your incision. We'll tell you on the morning after surgery whether you have skin staples or if you have dissolvable stitches, but changing your dressings after surgery is the same either way. We ask you to change your dressing once a day for the first 3 days after surgery. The morning I see you, oftentimes I'll change your dressing in the hospital. What I ask you to do is leave that dressing on overnight. I ask you not to shower that first post-operative day. On the next day after surgery, on post-operative day 2, if you wanted to shower with that dressing on from the night before. You'll take your wet dressing off and replace it with one of the clean, dry dressings we provide you with. So that's changing your dressing on post-operative day 2. On post-operative day 3, if you want to shower, you'll shower with your dressing on again. You'll take that wet dressing off and replace it with a clean, dry dressing. And then finally, that will be your last dressing that you'll have. On post-operative day 3, if you want to shower, you'll shower with your dressing on, then take that wet dressing off and leave the incision open to the air. As far as activity restrictions and limitations after surgery, we ask you to keep it to light lifting and light bending when you go home. Think about 5 to 10 pounds or about a gallon of milk weight-wise or 2 as far as lifting goes. Certainly you can be walking at home. We like you to be walking 2 or 3 times a day. You can go up and down stairs in your house. If you felt up for going out to dinner or going grocery shopping, those sort of normal activities are fine for you to do. When you get to the point that your muscles start to ache or you feel fatigued or tired, just sit down and rest. There are a few things I'd like you not to do the first month after surgery. That would be anything that requires a heavy lifting over 10 pounds. That would be formal exercise. I'd like you to wait until we see you in the office after surgery. And as far as driving, we do restrict you as well. I usually ask you to wait 1 to 2 weeks to get back to driving after surgery. And this is partially because of using pain medication. You can't get back to driving unless you're off pain medication. As well as symptoms can fluctuate in the arms and legs the first 2 to 4 weeks after surgery. So you need to make sure if you needed to slam on the brake, you're able to be safe to get back to driving. If you've had neck surgery, you need to make sure you have full range of motion of your neck in order to look in all directions so that you're safe to get back to driving as well. We will provide you with pain medication after surgery to go home with. Typically we'll use Percocet for pain and then we'll use a muscle relaxant called Xanaflex, and usually I'll go over those instructions as well as your nurse will before you leave the hospital.
After your spine surgery, you will have follow-up visits. Your initial visit is typically at 1 month after surgery. There is an exception. Some of my patients do require staples being put in after surgery. If you did have staples put in after surgery, you'll come to my office for a separate visit at 2 weeks, and that visit is strictly to get your staples taken out. Joyce will help you with that appointment. Typically when I see you back at 1 month, we will discuss activities that you're allowed to do. Typically what I tell people is they can increase your activities but not back to normal activity. So you could start to do some light exercises at 1 month after surgery. You could start to work out on an elliptical machine. You could be on a treadmill. You could be on a Stairmaster. You could ride a stationary bike. If you wanted to start to clean the house a little bit, do some light housework, light laundry, push the sweeper for 15 minutes to half an hour, that would all be fine. If you wanted to do some work out in the yard, some light gardening or mow the grass for 15 minutes at a time, that would be fine as well. Everything after surgery that first month is about your muscles healing. So you won't hurt the nerves or the bone, but you can hurt your muscles and you can strain them. So the restrictions I put on you are based upon not hurting your muscles after surgery. So I want you to gradually ease back into activities at your month visit, but I won't release you back to normal activity for a few more months after that. As far as any physical therapy goes, I just have to see how you're doing. Some people require physical therapy or would like to go to physical therapy, and if that's the case, we will write your prescription for that. I typically do physical therapy, including water therapy in a warm pool, as well as land therapy, and we typically do a 6-week course of that if you do go into therapy. We will also check on your incision to make sure incision is healing at your first visit. I'll answer any questions that you may have about remaining discomfort. The first month is a tiring month, so you have to expect it. You'll be very worn out, you'll be tired, you won't have any energy, and that's all normal for the first month. Your back should still be quite sore because the muscles are not healed, and if you still have pain in a limb, that can be normal as well. So the first visit is really just to make sure you're doing okay, take a look at your incision, make sure it's healing, make sure you have good strength in your arms and legs, and to answer any questions that you have and to increase your activity appropriately. After that, I do typically have you come in for a second visit at 3 months. And at 3 months, at this visit, it's really to see how you're doing and to really try to get you back into more normal activity. So I would let you go back to most activities that you want to do except for any extreme activities. People who run long distance marathons or who exercise very aggressively like P90X or do heavy lifting at their work, I may hold restrictions for a little bit longer, but typically at 3 months, that's the point in time where I let you get back into more normal activities. And usually by that time, if you were in therapy, you'll have finished your therapy and we can see how you're doing. And then at 3 months, I'll take the opportunity to answer any questions that you have, any ongoing problems we'll address at that visit as well. And typically we just have the 2 visits after that. On occasion, you will have a third visit if you're having problems or you need x-rays done for some reason. I will have you come back in at 6 months for an extra visit, but that's not the normal. As with any surgery, there are risks. We talked about many of these risks during the office visit. Typical risks that I mentioned for a lower back surgery with or without fusion would include things such as bleeding, infection, nerve injury, permanent weakness, paralysis, no change or worsening your symptoms. It can include things such as bowel or bladder dysfunction, spinal fluid leak requiring a repair. On the rare instance your spine didn't fuse, it could require further surgical intervention at that point as well. There are also the risk of anesthesia, risk to your heart, and there's always a small risk of death. Combining all of those things I just listed together is approximately a 1 to 2% risk of that happening. I've performed thousands and thousands of back surgery over the past 20 years, and I've never had a permanent nerve injury, and no one's ever been paralyzed. So I feel comfortable in telling you that I think you'll do well from your surgery, but I can never say 100% there could not be a complication. That's a part of having surgery, and there's always that small risk.